virtual CME on World Tuberculosis Day. This year's theme is Yes, we can end TB. Commit, invest, and deliver. India is committed to meeting the target of ending tuberculosis by 2025. Let us hope for the best results. Now I am inviting President Ahmedabad Medical Association, Dr. Dhiren Mehta sir, to say few words. Welcome, sir.
Thank you, Dr. Dabhi, and warm welcome to all. All of us know 4th March as a World Tuberculosis Day, and already Dr. Kalpita has informed the theme of Tuberculosis Day 2025. Let us imagine India and world without tuberculosis. All of us know very well that the world's deadliest infectious disease is the tuberculosis, which is devastating millions globally and inflicting health, social, and economic consequences. So let us try to end the TB earliest as possible, and for that let us learn regarding and let us know regarding tuberculosis from our experts, Dr. Tushar Patel, Dr. Jani, and Dr. Pradeep Dabhi. Thank you so much.
Thank you, sir. Now moving ahead, inviting Dr. Tushar Patel, sir, who is HOD Respiratory Medicine at GCS Medical College, Senior Pulmonologist at KD and Spurs Hospital, past President Ahmedabad Medical Association. We all knew sir's dhamakedar presidentship. Big round of applause for sir. And currently, sir is Treasurer IMA GSB. Welcome, sir. Sir's topic is role of IMA in elimination of TB. Welcome, sir.
Thank you, ma'am, for kind introduction. Kalpita, ma'am. First of all, I would like to thank on this occasion of 24th March, World TB Day, organize such a virtual CME on College of GP, College of GP Director, Dr. Jashwant Darbar, also Ahmedabad Medical Association President, Dr. Dhiren Mehta, sir, Secretary, Dr. Urvesh Shah, and our President of Gujarat State Branch, Dr. Mehul Shah, and Kalpita Ben Coordinator. Today's program mainly to why we celebrate the World TB Day. On 24th March, Dr. Robert Koch is invented the tuberculosis is caused by the Mycobacterium TB invented, and on that day, so since long WHO we are celebrating World TB Day program and World TB Day to create the awareness amongst the public and all our stakeholders regarding tuberculosis. So today's mainly theme of TB, the Kalpita Ben already says today's theme of the World TB Days. So IMA, mainly IMA role on World TB Day or on tuberculosis. IMA is the biggest organization in the world of doctors, those who are practicing allopathy. And these organizations is play a pivotal role since 1993. IMA play a major role to eradicate tuberculosis with joint hand with Government of India, central government, central TB divisions. Now also IMA make a MOU with central TB division to eliminate TB from the country. In this way, IMA, our members' main role is to notify a TB patient into the NICSI or any way into the government authority. So that's with help to the government to notify notifiable disease and count the patient, how many patient in geographical distributions of the patient, zone-wise distribution of the patient, which type of patient. Like nowadays, they increase the incidence of the MDR and XDR tuberculosis, this type of incident. But now that so many drugs is also available to eradicate the TB. So and a proper diagnosis, and government now start program in the next few minutes. Our two learned speaker, one Dr. Oza is from WHO consultant, and another is a clinician, topmost clinician, those who are doing not extensive work in the tuberculosis, also lung transplant. So, and also a truly academician, Dr. Pradeep Dabhi. Both are enumerate what is the TB and TB TB related treatment. So, TB is a mainly a notifiable disease by government of India. So we please I request to all our IMA members to notify the TB patients anyhow, anywhere, any way to notify the TB disease, and also help us government to relieve the stigma of tuberculosis. So this time IMA make a government MOU with to relieve the stigma and also to notify the disease of tuberculosis. So I would like to thank committee members to invite me such a thing. Thank you.
Thank you, sir. ટીમ વર્ક થી જો આપણે બધા કામ કરીશું તો શ્યોર આપણું આ થીમ સક્સેસ થઈ શકશે. વેરી ઇન્ફોર્મેટિવ સેશન, સર. થેન્ક યુ. Now I invite Dr. YK Jani, sir, who is working in TB since 8 years. He is MD PSM from IMA Medical College and he is NTEP consultant WHO Ahmedabad. Sir's topic is NTEP programmatic update. Welcome, sir.
So before Jani sir, we take the note of presence of Dr. Mahadev Desai, who is a mentor and guide for this our College of GP virtual CME and all other activities. Welcome, Dr. Mahadev sir also.
Thank you. Yeah.
So very good evening to all. I am Dr. YK Jani, working as state consultant for WHO in Gujarat state since last 4 years. And I am associated with this program since last 6 years. So I would straightway start with presentation. So hope it is visible.
Yes, sir, it's visible.
Okay, sir. Thank you, sir. So, as we know, our Honorable Prime Minister has committed to end TB by 2025, much ahead of end TB strategy, that is 2030. And this commitment was made in 5 years back in 2018 on World TB Day, 2018. So what are the criteria and goals for commitment to end TB? So there are basically 3 criteria: reduction in number of TB deaths, reduction in TB incidence in per lakh, and reduction in catastrophic cost, what we call out-of-pocket expenditure to the TB patient. So target is basically for India is 2025, although it is much far than we achieve, but it is there. So comparison is 2015, and we expect reduction in TB deaths by 90%. That the number of deaths should be 3 or less per lakh population. And similarly, incidence of TB should be 44 per lakh or less. That is 80% reduction as compared to year 2015. So these are much ambitious target, we know, and we are working, and also government is working hard to achieve this target. When we talk about global and national target for TB and DRTB, so globally around 1 crore of TB cases are notified, and out of that contribution of from India, it is around 25%. That is around 26 to 27 lakhs a year. And when we talk about TB mortality, so TB mortality in HIV negative people, it is 28.6% globally, and per lakh rate is 22. But when we talk about TB HIV mortality, it is much higher, 10 times higher in the TB HIV infected people with TB. Among MDR, global numbers, total 4 lakh of MDR drug resistance TB cases are reported. When we convert numbers into per lakh, it comes to 5 per lakh, and India also contributing around 27% for the drug resistance TB cases also. Again, in India, there are pockets like Mumbai and the corporation area in Gujarat like AMC, SMC. These are the hubs for drug resistance TB. annual incidence, as we epidemiologically TB burden is measured in per lakh population. So if we go by speed of 75% decline, right now we can achieve the said target of 44 per lakh, but our speed is around 17 to 18% with available strategies of diagnosis and preventive TB. So hope we work and fast together to achieve the targets. So what are the strategies and resources and technology available in the program to achieve the target? We will learn the update in this session. So with current strategies, that early diagnosis and treatment, notification, reporting, timely treatment, treatment adherence, we can achieve around 2% decline in the TB cases per year. But that is not good enough. What we need additional? We need new drugs, especially preventive aspect TB vaccine, effective TB vaccine for the adult TB patient and non-TB patients. We need more accurate treatment for drug resistance TB, effective treatment that can be achieved, so we can achieve around 90% success rate among DRTB cases. So what are we have in the newer strategies and currently implemented in the program? So I would start with the preventive part. Preventive part basically have two things: prevention of infection exogenously and prevention of infection endogenously. So for exogenous prevention, we have certain criteria, that air infection control kit in the hospitals, fast tracking of the respiratory tract infection patient in the OPDs of the bigger hospitals. So transmission can be prevented and infection chain can be broken. There should be separate cough corner for the sputum collection in the OPD areas and the larger hospital areas. For the prevention of the endogenous activation, that is latent TB infection, to prevent the activation from latent TB to active TB, we have TB preventive treatment currently in the program and the vaccination. But vaccination is basically for the at birth childhood vaccination. For adults, there are studies going on. So for TB preventive treatment, currently TB preventive treatment is being provided to the household context of pulmonary TB patients among PLHIV and other risk groups. Other risk groups include cancer patient, immunocompromised patient, transplant patients. Even there are more than 30 categories currently being covered in the program in TB preventive therapy. So this is burden of TB infection. We knew about the TB disease in the previous slide. So burden of TB infection is around 31.3% crude prevalence. This is based on the data received from the National TB Prevalence Survey. So even in general population, we can say there is 35 to 40% people are infected with the TB. And chances of breaking to TB or developing the TB disease among these people is 10% over the lifetime period. And mostly they break into the TB in the first 2 years after the infection. Study published in 2020 from India. What this study highlights that 70% of the household contact of pulmonary TB patient have baseline TB infection. Means higher chances of having TB infection among contacts and higher chances of breaking into the disease among these contacts. And among them, 2% household contact develop incidence in initial 2 years, as we discussed in the previous slide. Again, what are the independent risk factors for the developing TB disease? One is HIV infection, undernutrition, and others are old age. Means more than 60 years, diabetics, smokers, alcoholics, having higher chances of having TB infection, who may be contacts of TB patient or may not be. Independently, they are at risk. So this is site TB skin test currently being used in the program, TB program, National TB Elimination Program, for the investigation of the latent TB, for making the diagnosis of latent TB infection. So what is strategy? Contacts of TB patient are identified. they are screened for TB symptoms. They are screened by X-ray. If X-ray is negative, clinician rule out the TB, and they do test with site-TB skin test. If site-TB skin test comes positive, patient would be provided 3-month or 6-month of TB preventive therapy, what is available in the program. Various studies says that TPT is effective, and after providing TPT, eligible or at-risk patients can be prevented from having TB for the period of 6 to 19 years. These studies are done among various countries and areas like Alaska, Brazil, Temprano, Myanmar, and Indonesia. So, TPT and ART both together decrease the risk of developing TB by more than 80% based on various studies conducted in Brazil, Africa, and Botswana. So ART and TPT should not be given separately. In HIV patient, they should be given together. When we discuss TPT, mostly clinicians have apprehension of developing more drug resistance and more ADRs. But studies says that the ADRs are more or less equal to the drug sensitive TB treatment, around 1%, and no major side effects have been observed till today in the program. So as we discuss, who are the primary targets for TB preventive therapy? Target groups for TB preventive therapy are: first is people living with HIV, second is all household contacts or close contacts working at the same place, traveling together, and others are, as we discussed, that alcoholics, smokers, immunosuppressive patients or silicosis patient, diabetic patient, prisoners, healthcare workers, they all together are at risk for developing TB infection. So they should be targeted for TB preventive therapy after ruling out active TB. And these are the regimen options. 1 HP, H means Isonex and rifampicin, 28 dose daily. Other is 3 HP regimen. It includes 12 doses, weekly doses. And 6H was being used, and first TB preventive regimen was 6H was given for 180 days previously. Currently also they're in program, but 3 HP is the newer regimen. And currently we are having more acceptance and compliance to 3 HP regimen rather than 6H regimen. So what are the challenges for TB preventive therapy? In Gujarat in 2023, there were eligible to, around 50,000, say for 50,000 were eligible cases of TB. And considering the family size, 1.5 lakhs were eligible for TPT, means target for the TPT. Among them, 70%, around 1 lakh accepted the TPT. And TPT was initiated or provided from the program among 70,000, that is again 70%. And among them, completed patients were 35%. So barrier is at the level of acceptance and adherence. We see that acceptance is mainly challenged because patient is having no symptom, no any issue. And when we say that your X-ray is normal, they are a bit hesitant. Why should I have some treatment when I am not having any symptom? So these are current challenges, and we need support from the private physician and clinician to counsel patient and their contacts and relatives of TB patient for having acceptance for the TPT. Second primary prevention is vaccination. So at birth, we are providing BCG vaccination, but it is basically to prevent the complications or CNS TB in the children. But for the adults, currently we do not have any effective vaccine. Researches are going on. One big such research or implementation study is going on in India. That is revaccination with the BCG among eligible categories, that is more than 60 years, diabetic, smokers, alcoholics, contacts, and previously TB patient. So this study is currently going on, and we will have that result in near future, that whether it is effective or not. So preventive part is over, and now I would like to discuss update on diagnosis and treatment in TB program. So currently diagnosis method is on X-ray, microscopy, NAT machine, and LPA. Program is shifting to upfront molecular testing, that if any patient comes with the TB symptom, any of the TB symptom, we should provide with the upfront molecular testing, be it CB-NAT, be it TrueNAT, or any other validated technology approved by Central TB Division or ICMR and being used in our state. As we know, you all will be notifying or must be notifying TB cases to the nearest DTC or the program manager, and they will be asking for the samples for the NAT testing, be it CB-NAT machine or the TrueNAT machine. And we expect more extrapulmonary samples from the private sector, because in program we do have challenge for the sample collection in the extrapulmonary TB patients. So we expect quality samples from the private sector, and it will be tested at the nearby district TB center for the NAT testing. So this is pharmacological basis. I will not go in detail. You will be knowing much more than me in this aspect. So I am moving to the next slide. These are FDCs available in the program for the drug-sensitive TB patient treatment. Basically, Isonex, rifampicin, pyrazinamide, and ethambutol, 2-month IP phase and 4-month CP phase with 3 FDC. These are dispersible tablet based on weight band, not like blanket approval as previously. And program learned this thing from the private sector only. Initially, it was blanket approach, but came to know that one shoe does not fill all size. So this was innovation, and it is given under direct dots to the TB patient by the dot provider, ASHA or the community volunteer. And these are now standard drugs available in the program. And private practitioner also can give these drugs to the TB patient after coordination with the local DTO. For the drug resistance TB, these are the regimens available in the program. BPAL regimen is a newer regimen, recently launched by the program, and it is 6 to 9 months. Then number 2, 3, 4 are already existing in the program. 11 months, 9 to 11 months shorter oral regimen, 18 to 20 months oral longer regimen, 6 to 9 months H mono regimen. So this is diagnostic algorithm. I will summarize in brief that any symptomatic or all notified TB patient comes to a private physician, they should be tested for the NAT test. And if it is a patient is more than 14 years and if resistance is detected, he should be offered BPAL-M regimen, that is bedaquiline, pretomanid, linezolid, and moxifloxacin. And if it is less than 14 years and not meeting the inclusion criteria, then they should be considered for the longer oral regimen or the shorter oral regimen based on the inclusion criteria. If patient is not RIF resistance, he should be detected for the H resistance, and H resistance, if detected, should be followed with the H monotherapy, or if H resistance is not detected, it should be followed with the routine drug sensitive TB treatment. So this is BPAL-M total package. Slides will be shared so you can study the dose by dose treatment. Bedaquiline and pretomanid are initially continued for some time, and then it is routinely followed. But again, criteria is more than 14 years, not having hemoglobin less than 7%. There are certain inclusion criteria that should be met, and then it should be initiated. Shorter oral regimen, it is 9 to 11 months regimen, 4 months for intensive phase, 6 months for the 5 to 6 months for the continuation phase, and bedaquiline is being given for the 6 months. So it is not newer thing, already in the program since last 4 to 5 years. Oral longer is also in the program, 18 to 20 months. Initially, it was bedaquiline-based regimen, so it is also having good outcome ratio. The shorter is having 75%, and oral is also having nearly 75% success rate. These both regimens are good, and we are expecting 90% success rate with the BPAL-M regimen. This is H mono regimen, more or like drug sensitive TB treatment, 6-month treatment, may be extended up to 9 months. So now diagnosis and treatment part is over. What is update for the Nikshay Poshan Yojana, the patient support system? Currently, TB patient, any TB patient, public patient or the private patient, is provided monetary benefit of ₹1,000 per month till the treatment continues. And PMTB-MBA, under PMTB-MBA, Pradhan Mantri TB Mukt Bharat Abhiyan, patient is being provided nutrition kit, but support is leveraged from the donors. Program itself does not directly support. They leverage support from the CSR or be it IMA or any industrial or the political support. They facilitate the kit provision, nutrition kit provision to the TB patient. What are the various incentives available under the National TB Elimination Program? So if private provider do notification, per notification they will get ₹500 monetary benefit. If they give outcome, they will again get ₹500 monetary benefit. Informant incentive for if any TB patient self-notify his or herself, they will get ₹500. For the treatment support honorarium, there are certain provision of ₹1,000, 5,000, and ₹250, respectively, for drug sensitive TB, drug resistance TB, and TB preventive treatment. If private provider or their staff supports treatment, program will also provide monetary benefit to them. Nikshay. Lastly, I will talk about Nikshay. We hope that each and every private practitioner is registered in the Nikshay portal. They do notification themselves. They do patient tracking and treatment adherence monitoring for the sake of the benefit of the patient. Because you are or all are renowned physician, and patient may come to you from the different districts and different states also. So it will be easy for the program to track the patient and to provide them all the eligible public health actions. So we assure your prompt and highest quality of services without affecting confidentiality of the TB patient. And in the last, I thank you, IMA Ahmedabad, for giving me opportunity for the session. So I conclude here. Any query? Most welcome.
Thank you, sir. Very nice presentation, sir. I think private practitioner na involvement થી acceptance, diagnosis, treatment બધામાં ફરક પડશે ને easy પડશે. Now I invite Dr. Pradeep Dabhi, sir, who is a consultant pulmonologist at KD and Spurs Hospital. Sir did his MD from MP Shah Jamnagar and did fellowship from CMC Vellore. Welcome, sir. Sir's topic is the clinical presentation and newer diagnosis of pulmonary TB. Welcome, sir.
Thank you, ma'am. Is my slide is visible?
No.
Now it's okay?
Yes, sir. That's okay.
Thank you. Thank you, Indian Medical Association, for giving me this opportunity to speak in front of all of you. I would like to thank Dr. Tushar sir and Indian Medical Association. So my job is very clear, and It's a clinical presentation and newer diagnosis of pulmonary TB. As sir mentioned, my job is a little bit easy. He has given all the details about the 2025 slogan to end TB strategy. So government is come up with private practitioner to find the latent TB cases, to find the early diagnostic modalities, to have a very beautiful and insightful of molecular diagnostic, which is very, very useful and very early detection of the pulmonary TB and extrapulmonary TB. So without wasting much time, my job is to just focus on pulmonary diseases. As we all know, pulmonary diseases is categorized in these 5 or 6 categories. Some are tissue related like lung parenchymal disease, some are airway disease, some are pleural disease, some are mediastinal disease and vascular problems. So TB involves out of these 5 or all 4 diseases. Like parenchyma, it's called pulmonary TB. Airway, it is called endobronchial TB. Pleural TB, as we all know, which is also a very common TB. And one more form of TB is mediastinal lymph nodes related TB. So this is how we as a clinician see as a pulmonary system and pulmonary TB patient. So these are the basically a 3 type of pulmonary TB: parenchymal, pleural, and mediastinal. So how they present to us in clinical practice? So cough for more than 15 days, as we all know, and cough for any duration in specific population, like patient having a context of pulmonary TB, having cough of any duration, people with HIV having cough of any duration, immunocompromised host, somebody is on long-term steroids, taking anti-cancer drugs, post bone marrow or solid organ transplant recipients having cough of any duration. This is the most common symptoms, followed by hemoptysis, low-grade fever, and few are constitutional symptoms in the form of loss of appetite, loss of weight, and feverish feeling, night sweats. Dyspnea on exertion is least common symptoms amongst the pulmonary TB. So if this type of presentation of a patient, we should suspect a pulmonary TB in this population. Another definition is endobronchial TB. We as a clinician, we as an interventionist, we see lot of patients having a endobronchial involvement of tuberculosis, and which is very, very challenging. In spite of giving AKT, the patient is having a persistence of symptoms and he may need a help of interventionist. So if it involves the tracheobronchial tree with microbiological and or histopathological evidence, regardless of their lung parenchymal involvement. We see one of these example in next couple of slides. So as we all know, this is our tracheobronchial tree. It starts from larynx up to the bronchiole, which is divided into trachea, left and right main bronchus. It is just like a branch of a tree. So this part of the lung bronchus or trachea or bronchiole is involved, which we term as endobronchial TB. Depend upon the site of this involvement, patient present with not this typical of symptoms of parenchymal TB. Here the symptoms is little bit different than pulmonary tuberculosis. Here the symptom is like bronchial asthma, cough which is unresponsive, barking type of cough, wheeze which is monophonic wheeze or stridor, which suggests stenosis. Dyspnea, hemoptysis, and chest pain are less common. Systemic symptoms is also less prominent in endobronchial tuberculosis. And if you do a clinical examination by auscultation, you may need to have a decreased breath sounds because of the collapse of that particular part of the lung, or a monophonic wheeze or a rhonchi. So here the presentation is a bit different. That's why I put forward this definition. Pleural TB symptoms is also a little bit different. It's a pleuritic chest pain. Otherwise, the symptoms are same. Mediastinal TB symptoms is very, very less because once the enlarged lymph nodes is not going to do a compression of the airway, it won't produce any symptoms. Sometimes the patient is evaluated for long-term fever for 1 month, 2 months. They do all the investigation and finally turns out to be a mediastinal lymph nodes. So these are all symptomatology comes under a category of a lung TB or a pulmonary TB. So how do you diagnose this type of tuberculosis? So above symptoms, we call as a pulmonary TB suspect plus investigation. So once the patient present with these symptoms, we do imaging first. The first and foremost is X-ray chest. Some of the abnormality you couldn't find out in X-ray because X-ray has its own limitation. So if a patient's X-ray is normal, it is not 100% that the patient is not suffering from tuberculosis. Then we need to do a CT scan of the chest, which is more precise, and that gives us and guides us where the abnormality is located and which type of abnormality is located in the CT scan. USG chest is also again a more sensitive and specific marker to diagnose pleural tuberculosis. Then the most common test, as sir mentioned in previous slide, sputum examination, which is very, very common test and which is nowadays is freely available under the program. We can do even a molecular test, sputum for AFB smear, gene expert, AFB culture, and we diagnose the tuberculosis. And sometimes even the sputum can miss a minor abnormalities in the X-ray or in the abnormality only in the CT scan. So if the sputum is negative, previously in the program, there was a definition of sputum smear negative tuberculosis. But nowadays that definition is taken care of. And there are options of special investigation in the form of bronchoscopy to diagnose the endobronchial tuberculosis or a pulmonary tuberculosis, pleuroscopy or pleural fluid examination to diagnose a pleural TB, and a newer tool is endobronchial ultrasound to diagnose the mediastinal TB. So these are the special tests which required to confirm the diagnosis of TB. Sometimes what happens, patient is on empiric AKT and it turns out to be, once we do this type of special procedures or special investigation, it turns out to be a different etiology or different pathology in same patient, and patient is taking the AKT wrongly. And which is this investigation also helps in taking care of early diagnosis of tuberculosis. So these are the pictorial of these procedures. You can see where is the pathology is located. If you can see if the pathology is in the airway, bronchoscopy will help. Percutaneous lung biopsy will help. If there is a pleural effusion, pleural tap or thoracoscopy will help. And side by if the lymph nodes is there, EBUS or EUS guided biopsy can help. So now my next slide is why microbiological diagnosis of TB is important. So sir has rightly mentioned, now the program is also shift from smear to solid culture to liquid culture, and now everything is on molecular. So molecular is very, very important to categorize the patient because we have lots of H monoresistant cases, MDR cases, and so forth and so on. So to diagnose this type of patient very early, molecular diagnosis is prime for the program to prevent the TB, to treat the TB, and to prevent the contagiousness of this infection. So failure to perform a proper diagnostic evaluation before initiation of treatment exposes the patient to the risk of unnecessary or wrong treatment, delay accurate diagnosis and proper treatment, and increase the drug resistance of tuberculosis. So that's why the microbiological diagnosis is very important. And even the advantage of microbiological test is very suitable for non-viable specimens which can be killed during drug therapy. Contaminated specimen, it can also be performed. This molecular diagnostic test differentiate the MTB from other non-tuberculous mycobacterium tuberculosis where the treatment is totally different. It can be applied in a large number of specimens at the same time and to give a very accurate results. Another advantage, it gives you a phenotypic resistance pattern, and even it can pick the gene, which specific gene is responsible for which specific antibiotic. And it is ability to identify this mutation to optimize the treatment by switching the more potent drug regimen. So molecular diagnosis is prime for the program, as sir mentioned previously. So what are those methods, molecular methods? So real-time PCR, line probe assay, gene expert, and pyrosequencing. So these are the methods. And in the program, as we all know, gene expert is very popular test, and nowadays everybody knows. So before that, we just have a couple of slides for line probe assay. So it's an automated test, line probe assay. So how they do a DNA extraction, amplification of the PCR, then they do the hybridization of that segment of the DNA, and then they evaluate the gene, which mutant is available. And this identify particular gene for this particular drug. And but the requirement of this test is your smear should be positive for the test to perform the line probe assay. For smear negative tuberculosis test, or if the bacillary load is low, then the pickup rate of this test is a little bit low. So this is the performance of MDR TB plus in all specimen. You can see the sensitivity and specificity is above 90%. Similarly, the gene expert, which is widely accepted test, the correct name is expert Mycobacterium tuberculosis RIF. RIF is the test where it looks for the rifampicin resistance, not for the INH resistance. So it's a simplified test. The turnaround time is less than 2 hours, which is very specific for Mycobacterium tuberculosis, totally automated test. And these are the steps. Once we take the samples, we add the reagent to inactivate or inhibit the samples. Then we transfer these 2 ml of that samples into the special cartridge. And in that cartridge, there is a 4 steps, 4, 5, 6, and 7. And finally, you got the results automatically. Though here the false negative is very, very low. And you can see the result is like MTEP detected low and rifampicin resistance is detected or not detected. So it's a very simple test and which can be done in all specimens, and the sensitivity and specificity for sputum and bronchoalveolar lavage is very, very high compared to extrapulmonary specimens. In extrapulmonary specimens, the bacillary load is low, so the sensitivity and specificity is low. So you can see sensitivity in smear positive and culture positive is 99%. And in smear negative and culture positive specimen is 90%. So almost replacing the smear examination. The sensitivity for AFB smear for pulmonary TB is just less than 40%. Here it is 90%. And the advantage of this test is detection time. You can see solid culture will take more than 30 days. Liquid culture will take more than 17 days. Microscopy is for 1 day, and expert TB is less than a day or less than 2 hours. And you required a very less number of bacteria, and you required only 10 to 100 CFU colony forming unit per ml of sputum for culture. And in this expert assay, you need only 131. So this is the study published in Rapid and Effective Diagnosis of Tuberculosis in Rifampicin Resistance with expert MTB and RIF. Its capacity to diagnose rifampicin resistance, sensitivity and specificity is above almost 95 to 97%. So without wasting my time, it's almost what I wanted to know is diagnosis of tuberculosis, importance of molecular diagnosis. And now I quickly jump into the cases. I have 3 cases to discuss. Each category one case. So this is a 16-year-old boy, cough with sputum, low-grade fever, streaky hemoptysis, weight loss 5 kg. Duration of the symptoms is 3 months, no wheeze, chest pain, dyspnea, and he has a decreased air entry in right infraclavicular area. Went to a local physician, all normal blood workups. HIV is negative. A sputum was done, which is gene expert, and AB smear was negative. Chest X-ray shows right lung mass-like opacity with right mild pleural effusion. And CT was done outside and he came to us. So this was the X-ray. You can see a cavitary lesions in the right upper zone and mid zone. And this is the CT scan. You can see the breakdown and you can see the bronchogenic nodules in the right upper lobe anterior segment. So we went ahead and because of sputum is negative, we did a bronchoscopy. This is the video of the bronchoscope. This is the trachea. We went ahead and see the changes in the right upper lobe as per the CT scan. You can see the white in the posterior segment. You can see the white flex-like tissues, which is very, very typical of endobronchial tuberculosis. This is the left side. Left side is normal. Then we collect the lavage from the same segments. And then we took the biopsy also from the same segments to confirm the diagnosis. This is how we took the biopsy from the right upper lobe. It's a very soft. So before we move on, this is the radiological pictures of endobronchial tuberculosis. You can see the nodules, which is TIB, tree in bud appearance of the nodules around the bronchus. And then this nodules coalesces to form the consolidation and necrotic-like cavitation. And then it becomes, when it progresses towards the lobar bronchus, it causes the collapse. So these are the features of endobronchial tuberculosis on CT scan. So these are the endobronchial tuberculosis images of the bronchoscopy. Once the patient is having active TB, at that time he has a necrotic type of lesions in the bronchus. Then the lymph node can encroach into the main bronchus, and it causes the broncholyth formation. And at the end of the tuberculosis treatment, it becomes the fibrostenotic type of the bronchus. So these are the various features of endobronchial TB on bronchoscopically. So this patient turns out to be a tuberculosis on bronchoscopic biopsy, as well as gene expert was positive on BAL, detected low and rifampicin sensitive. Now we move on to the second case. It's a mediastinal pathology. It's the highlight is poor correlation of radiology and histopathology. So this is a 58-year female patient, no comorbidities, but she had background history of carcinoma breast, which was treated with surgery and chemo for 6 cycles. And she presented in July 2018. She was asymptomatic, but PET scan shows some mediastinal lymph nodes. She doesn't have any symptoms, which is very small lymph node of 13 by 16.5 mm in left hilar region with PET positivity. No recurrence at local site. So when there is a lymph nodes in the mediastinum, we usually, with the background history of cancer, we usually thought it's a cancer only. But oncologists referred to us to confirm the diagnosis. So what we do here, we do an endobronchial ultrasound, is a specific type of scope where the ultrasound probe is attached to the bronchoscope, and we see the lymph nodes around the bronchus, and we do a real-time needle aspiration as we do ultrasound guided biopsy of the neck lymph nodes. Similar way, we see the heterogeneous structures in the left hilum. We do a ultrasound guided biopsy of this lymph node. You can see the needle is piercing this lymph node. And then we took the biopsy of this lymph node. So this EBUS TBNA, it's turned out to be a tuberculosis. The patient is having carcinoma breast, and it came as biopsy suggestive of TB. Even gene expert and AFB culture was positive. We started on 4-drug weight-based AKT, and repeat PET after 6 months shows no lymph nodes. So this is how the newer technology helps to take care of the mediastinal pathology. So what is EBUS? Is stand for endobronchial ultrasound. It is a tool to look beyond the airway lumen and to sample various types of lymph node and to sample solitary pulmonary nodules. This is the pictures of EBUS scope. Last case is about the pleura. This is a 65-year lady, progressive breathlessness, dry cough, right-sided chest pain for 3 months duration, no significant past history. Somebody has done pleural aspiration, which was lymphocytic, exudative, and ADA of 45. As we all know, ADA, pleural fluid ADA is a strong marker for tuberculosis. So when the ADA is less than 40, it rules out TB. If it is 40 to 60, it may suspect the tuberculosis. If it is more than 60, it is a strong indicator of pleural TB. But here it is in the suspect range, not the confirmed TB. Fluid cytology and gene expert was negative. Started on 4-drug AKT by a local physician, and after starting AKT, he again had a fluid. And CT thorax shows right moderate pleural effusion with passive collapse of right lower lobe and lymph nodes. So we did a pleuroscopy. You can see the pleural fluid. This is the part of lung, and you can see the deposits in the pleura. This is the underlying lung. This is the pleural pill we took out. And then we took the biopsy from these deposits, and this came out to be a malignancy. So this is how the technology changes the diagnosis. Patient is taking AKT for more than 1 month, no symptomatic benefit, and this simple daycare procedure can change the diagnosis. So this is the end of my talk, and I have a few learning points. So suspect endobronchial TB and its complication in all pulmonary TB cases is in every scheduled visit. Do a sputum examination, which is a very non-invasive test. And if you pick up, but don't stop at sputum examination, when you suspect a very strong evidence of a tuberculosis or any other alternative diagnosis, do a CT scan or a bronchoscopy or EBUS, whatever is needed. Do not start AKT just based on clinical and radiological finding. Always do a microbiological proof. Endobronchial TB is the most common cause for benign airway strictures. Once the TB has gone with the AKT, but this type of strictures, patient is symptomatic and they comes to visit us very regularly. And timely done and airway interventions help in restoring this type of airways. Thank you very much. Any question? I'm happy to take those questions.
Thank you, sir. Very informative session with different case studies. Now we are towards the end of the CME. I request Dr. Smita Madam for the vote of thanks.
Before vote of thanks, I would like to have a 2 or 3 questions which are on our side. So, what is CYTV skin test first? Jani Sahib is there? Happy sir, if you can answer CYTV skin test. The second question is, what is the incidence of extrapulmonary TB? And the treatment protocol is same or duration is longer?
No, similar protocol in extrapulmonary TB also. In some cases like drug sensitive cases, 6 months, but in some cases may extend up to 3 months more.
Okay. And how will you identify this endobronchial TB by symptoms only and diagnose endobronchial lavage only? When a simple family physician like me will suspect endobronchial TB?
Endobronchial TB identify only this clinical by the endoscope and all this thing. Without endoscopy, no, we cannot identify because X-ray was normal. Patient complained persistent coughing, and some low-grade fever and weight loss sometimes.
Okay. Sir, Madhav Bhai is there. Would you like to add anything, sir?
No, I think we must compliment all the 3 speakers, right, from Dr. Tushar Bhai, who stressed about the tuberculosis is a notifiable disease. I think that is the first message we must send to all our colleagues. And its government has both incentive and disincentive both. That means if you don't notify, there are penalties, and if you notify, you get the remuneration. So that is first message. Second, Dr. Jani has excellently presented the present scenario and how we have yet not achieved the target, but probably we are going to achieve the way, the enthusiasm with which the department works. And Dr. Dabhi has rightly pointed the 3 cases in which he has shown that when you are suspecting TB, probably end up with malignancy. And when you have a patient with malignancy and suspected malignancy, it turns out to be tuberculosis. So I think they are all very eye-opener and very easily understandable languages they have all used, and excellent talk. But the same question that you asked, I also would have asked about. It looks like a tuberculin test only, but
yeah, tuberculin test.
Exactly. Yeah.
Yes, this tuberculin test type of test, but I don't know about this much.
Yeah. Thank you.
Okay, then we'll ask our person to Jani sir and then later let me know.
I think he's there now that his name is appearing.
Jani sir, are you there?
Yes, sir.
This our CYTB skin testing and relevance, interpretation and everything.
Relevance in?
CYTB
skin test.
Yeah.
As a skin test, basically in program there was tuberculin skin test. IGRA was also there, but feasibility wise and operational aspect wise, TST tuberculin skin test and this CYTB test, they are more user friendly from the provider aspect. And from efficacy wise, IGRA is much better than this both TST and this CYTB test. Efficacy wise and sensitivity wise, IGRA is better. But again, there is hesitancy and apprehension and anxiety related with the blood collection in the field. So from the program aspect and cost effectiveness wise, this CYTB is much more feasible than TST and IGRA test. So program has validated and implemented this CYTB testing in the current NTEP guidelines.
How to perform CYTB? Similar
Intradermal
to
test.
tuberculin test?
Similar to TST test, a skin test, intradermal injection.
And
0.5
interpretation?
ml.
Interpretation is
The
same?
interpretation is like similar to like TST. Injection is given to the any eligible beneficiary, and in the forearm intradermally, and the induration is checked after 48 to 72 hours. Induration is more than 5 mm, then it is believed that the patient is having latent TB infection, and if it is less, then patient is not having any infection.
Okay. Kamlesh, do you have one question? I think. Can you ask?
Unmute karo, unmute.
Unmute kar, Kamlesh.
कमलेश भाई अनम्यूट करो તમે.
Hello.
Yeah.
Sir, previously we are starting AKT after radiological diagnosis proof X-ray chest. Here you told, Dr. Dabhi sir told, if radiological positive, still we have to do microbiological confirmation.
Yes, it is necessary, because as we saw in our cases also, when the symptoms and X-ray can mimic some other abnormalities. If you have a radiological diagnosis of, there is no typical radiological diagnosis of pulmonary TB or any other TB. Similar shadow can be seen in fungal infection. Similar shadow can be seen in malignancy also. So you need a microbiological proof. As we all know, previously there was no molecular testing available, but nowadays the facility of molecular testing is there. That can pick up a very small number of abnormalities. So once the facility is available, why can't we do that test?
Is there importance of any TB gold test for diagnosis of tuberculosis?
TB gold test. Therefore, diagnosis of TB, once if you can't able to take the samples from any sites, and the radiological finding, clinical finding is suggestive of tuberculosis, and to add that diagnosis can sometimes help. But practically in pulmonary TB cases, we don't require that. We took the samples, as we all know. And there are a lot of instruments nowadays available to take the samples from the lung, from the mediastinum, from the pleura. So I don't think so tuberculin test or IGRA test is required to diagnose the TB. For latent TB diagnosis, yes. But for the active TB, it's not required.
Thank you, sir.
I think there are no more questions. Over to Smita.
Madam, unmute karo.
Audible?
Yeah.
Good afternoon, everyone. It gives me a pleasure to deliver the vote of thanks for this virtual CME World Tuberculosis Day to all dignitaries here. Let me first of all start by giving a glory to Almighty God for making this CME a resounding success. On behalf of IMA College of GP Gujarat State Branch, I, Dr. Smita Shah, would like to thank our Chief Patron, Dr. Ketan Desai Sir, past presidents, IMA, WMA, and FCI, and also thanks to Dr. Anil Bhai Nayak Sir, President IMA. I would like to thank Our speaker, Dr. Tushar sir, Dr. Jani sir, and Dr. Pradeep Dabhi sir for sharing their knowledge with us. Your presence has made the CME an inspiring experience for all of us. All the speaker gives excellent knowledge to us. All the speaker aim is eradication to TB. I hope this CME will helpful in eradication of TB from our country. A special words of appreciation goes to our dedicated team who work tirelessly behind the scene. Thank you, Dr. Kalpita, for coordination. I would also like to thank Dr. Mehul sir, GSB IMA President, Dr. Gargi, GSB Secretary, Dr. Darbar Sahib, Dr. Vasant Bhai. At last but not least, thank you each and everyone who present here. I also thank you, Dr. Dhiren sir, President of AMA, and Urman Bhai. Thank you all of you. Jai IMA, Jai AMA.
After that, we conclude the session, and I would like to impart a few knowledge. This College of GP is doing regular CME on 2nd or 4th Thursday of every month. And we also have a lot many certified courses, and we also have FCGP degree course also. You can go to the website and have more information. So we conclude the session, and thank you.
Thank you.